Chapter 2. Clinical Presentations. 2A. Tick bites. The Ixodes scapularis tick, or deer tick, monopolizes public attention. However, other ticks have also been identified that carry tick-borne diseases. Topic 1. Ticks responsible for tick-borne illnesses in the U.S. Read about where the ticks are found and what the tick transmits via the CDC website. The following ticks are discussed: Lone Star tick, American dog tick, groundhog tick, Gulf Coast tick, Rocky Mountain wood tick, soft tick, and deer tick. Topic 2. How to identify a tick. Topic 3. Tick-borne infections identified by the CDC. Anaplasmosis, babesiosis, Borrelia mayonii, Borrelia miyamotoi, bourbon virus, Colorado tick fever, ehrlichiosis, Heartland virus, Lyme disease, Powassan disease, Rocky Mountain spotted fever, RMSF, STARI, Southern tick-associated rash illness, tick-borne relapsing fever, TBRF, tularemia, and 364D, rickettsiosis, Rickettsia philippi proposed. Topic 4. Doctors can even struggle to identify a tick. The survey was simple. Each medical provider was asked to look out 1 5/8 inches by 2 inches high-resolution color pictures of ticks provided by the University of Rhode Island Tick Encounter Resource Center. The investigators made it easy choosing adult rather than nymphal ticks for the quiz. Laga et al., 2021. Medical students and non-physician healthcare providers, that is, nurses or physician's assistants, fared the worst, with only about 25% correctly identifying the ticks. Moreover, partly engorged ticks were even tougher to discern. Their article was titled, "Proficiency at Tick Identification by Pathologists and Clinicians is Poor." Topic 5. Discover how a tick was attached to an eyelid for 5 days. The patient's mother reported noticing a small foreign body protruding from her daughter's eyelid, increasing gradually in size over the course of 5 days. A slit lamp revealed a large tick deeply anchored into the right upper eyelid. Giroudi et al., 2019. The doctors removed the deer tick embedded in the eyelid. Our surgical approach hereby included total excision of the tick with its attached eyelid, wrote the authors. The procedure included removing a small portion of the child's eyelid along with the engorged tick. Giroudi et al., 2019. Topic 6. Ever wonder how long Lyme disease has been around? Scientists now know that ticks were present millions of years ago, and that the Borrelia spirochete has been infecting humans for thousands of years. Professor George Poinar, Jr., a paleoentomologist and parasitologist, discovered ticks preserved in a piece of amber estimated to be between 15 and 20 million years old. Spirochete-like cells were even found in one of the 4 preserved ticks. Topic 7. Lyme disease has been recorded for at least 5,300 years. In Ontario, Canada, a team member from McMaster University's Division of Rheumatology found evidence of Lyme disease in the bodily tissues of a 5,300-year-old male frozen in a glacier pool in the Italian Alps, colloquially referred to as the Iceman, or Ötzi. The genome sequencing of his DNA also identified that he had been infected with the spirochete Borrelia burgdorferi, the causative pathogen of Lyme disease. Keller et al., 2012. Ticks have been around for about 200,000 years, as long as humans have been alive, believes Poinar. I'm sure that they, our human ancestors, suffered from ailments caused by spirochetes carried by ticks. Scientific America, 2014. Topic 8. Larval ticks can transmit Borrelia miyamotoi. Nymphal and deer ticks are known to harbor pathogens. Astonishingly, a new study recently discovered that larval ticks, which are even smaller, may pose an equal risk to public safety. Female ticks infected with Borrelia miyamotoi could pass the bacteria to their eggs by the transmission of eggs to the larva. Han et al., 2019. They concluded that while nymphs pose the greatest epidemiological risk for several I. scapularis-borne pathogens, larvae may pose an important and possibly the greatest risk for BMD, Borrelia miyamotoi disease, due to their high abundance and tiny size. Han et al., 2019. Topic 9. Borrelia miyamotoi transmission from tick eggs to larva. The deer tick has 4 life stages: egg, larva, nymph, and adult. After hatching, a tick must eat a blood meal, or host, at every phase to survive. Researchers have long believed that adult female ticks do not transfer pathogens to their eggs. Therefore, larval ticks were considered safe and pathogen-free. Yet a new study sheds light on disease transmission throughout a tick's life and suggests we take these tiny microscopic larvae more seriously. According to investigators from the Centers for Disease Control and Prevention, CDC, larval ticks may already be infected with Borrelia miyamotoi after hatching from eggs. Breuner et al., 2018. This occurs through transovarial transmissions from an adult tick to its offspring by infecting the eggs with the B. miyamotoi bacteria in its ovary. Topic 10. You may be the tick's next meal. A partially fed tick may be able to transmit diseases faster. Partially fed ticks able to reattach could result from detachment from dead animals or possibly by host grooming. Eisen, 2018. Eisen documented that infected I. scapularis nymph ticks previously attached to a host for 24 to 48 hours, then removed and placed onto a new host, can still transmit B. burgdorferi spirochete within 24 hours of reattachment. Topic 11. People underestimate the time a tick has been attached. A summary of published data from the United States indicated that less than half of Lyme disease patients were aware of a tick bite in most studies, and even fewer, typically 20 to 25%, could recall a tick bite at an erythema migrans, or bullseye, rash site. Eisen, 2018. When doctors ask their patients how long a tick has been attached, that estimate may be off, warns Eisen. A tick bite victim's impression of how long a nymphal ixodes tick was attached before detection and removal should therefore be regarded as an underestimate. Consequently, a self-assessed tick attachment duration of less versus over 24 hours is of questionable value for a medical treatment decision in a suspected Lyme disease patient. Eisen, 2018. Topic 12. A minority of children with Lyme recalled a tick bite. The study examined 325 children with Lyme disease, evaluated at 6 emergency medicine departments within Lyme endemic regions. Negrovic et al., 2019. The children were diagnosed with Lyme disease based upon the presence of an erythema migrans, bullseye rash, or a positive or equivocal C6-EIA followed by a positive immunoblot. Only a minority, 18.5%, of the children recalled a tick bite preceding their illness. We demonstrate a lack of tick bite history does not reliably exclude the possibility of Lyme disease for children from endemic areas. Negrovic et al., 2019. Topic 13. A deer tick was attached to a girl's ear for 4 days. A 7-year-old girl had a partially engorged black-legged tick attached to her ear, which was estimated to have been feeding for 4 days. The picture is included in an article discussing the growing awareness of Babesia duncani in the eastern U.S. and Canada. Scott and Scott, 2018. The mother or child was not aware of the tick. When a tick bites its host, the hypostome secretes a compound that anesthetizes the skin at the point of entry. Consequently, the majority of patients do not recall a tick bite. Scott and Scott, 2018. Whenever a patient has a tick bite, health practitioners must watch for B. duncani infections and include human babesiosis in their differential diagnosis. Scott and Scott, 2018. Topic 14. A tick bite can lead to multiple co-infections. A man tested positive for Borrelia burgdorferi, Anaplasma phagocytophilum, and Babesia macroti serologies. His symptoms improved with treatment, but 1 year later he continued to experience neuropathy symptoms at the site of the presumed insect bite. Physicians must maintain a high level of suspicion for co-infection, as untreated disease can result in long-term and sometimes life-threatening sequelae. Grant et al., 2021. 2b. Types of rashes. Investigators often describe a bullseye rash in individuals with early Lyme disease. There is a growing number of other types of rashes in early Lyme disease and initial disseminated Lyme rash. The name of the rash has been changed from erythema chronic migrans, ECM, to erythema migrans, EM, as Lyme disease rashes often do not expand in size. Unfortunately, individuals with Lyme often never develop a rash. Topic 1. A list of other common manifestations of Lyme disease. Early Lyme disease, LD with rash, Bell's palsy, synovitis, heart block, and meningitis. Neuropsychiatric Lyme disease. Pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, PANDAS. Pediatric neuropsychiatric disorders, PANS. Lyme carditis. Autoimmune dysfunction, POTS. Post-treatment Lyme fatigue. Post-Lyme disease. Neuropathic pain. Persistent symptoms after Lyme disease. Concurrent co-infections. And post-treatment Lyme disease syndrome, PTLDS. Author's note. Currently, there is no reliable test to rule out a persistent tick-borne infection, so this term is used reluctantly. Topic 2. As few as 1 out of 5 Lyme rashes had a bullseye. Only 20% of patients with an EM, erythema migrans rash, in the U.S. present with lesions that have the central clearing of a classic target lesion, ring within a ring, or bullseye. Berlina et al., 2020. EM lesions are more uniformly red or bluish-red and lack central clearing. Berlina et al., 2020. Furthermore, between 4% and 8% of Lyme disease rashes presented with central blistering. Lastly, about 20% of patients have multiple EM rashes at the time of diagnosis due to the Lyme spirochete disseminating to other areas of the body. Topic 3. Diversity of Lyme rashes. A study shows the diversity of Lyme disease rashes. EM size increased over time, with the EM duration peaking at 14 days. Males had larger rashes than females, an average of 2.8 centimeters larger. Males were more likely to have a blue or red rash, but females were 65% more likely to have a red rash. Age was a key predictor of central clearing. As age increased by 10 years, the odds of central clearing decreased by 25%, creating more likelihood of a solid rash. EM rashes were more likely to occur in harder-to-see body locations, that is, behind the thigh and knees. Nearly 1 in 3 patients had multiple rashes on examination. Nearly 1 in 3 patients reported pain at the rash site. Just over 50% of the EM rashes were itchy. Rash shapes differed. 50.9% were round. 39.1% were oval. The remainder were irregular. Rash colors were varied. About 3 out of 4 were red, and the other ones were blue-red. Rash patterns were assorted. Only 28% appeared as a bullseye rash. Central lightness, 17.3%, central darkness, 28.8%, and uniform rashes, 25.8%, were also described. Over 90% of the rashes were homogeneous. The remaining rashes were uneven. Nearly 9% presented with vesicles. Rebman et al., 2021. Author's note: many EM rashes do not expand in size.